I would like to introduce Dr. Ludi Shi, who is one of the movement disorder specialists in our center, also the director of our deep brain stimulation program. And so thank you. And also I want to say Dr. Shi is the person who puts this Ask the Experts program together for the past however many years. And so we really have her to thank for doing this for us.
And can you all hear me okay here? Yep, okay. On that note, though, I think Althea Silver and Lauren Anderson get all the credit for actually doing the nuts and bolts of putting all this together, getting the room organized, having you all come in here. And thanks for coming in on this rainy Saturday morning. We need the rain, but I'm sure it was made the roads a bit slower. So today we'll talk about ups and downs of your Parkinson's medications. Okay, good. So I think as a disclaimer, though, we're going to talk about these medications in general terms, but you should always talk with your neurologist about, whether these things are right for you or why this or that wouldn't be recommended for you or and so forth. So everybody's situation is so unique. And as we teach all of our fellows and residents, once you've seen a case of Parkinson's disease, you've seen one case of Parkinson's disease, right? Everybody has different responses to these things and different side effects. And so you always have to take that with a grain of salt. So let's see. There we go. All right, so we'll just get down to the basics. And a lot of this is in your handout. So you don't need to worry so much about taking notes. But as we all know, Parkinson's disease is a neurologic disease which affects dopamine-producing neurons, aside from others.
Yes.
Yeah. Okay, sorry. Can you all hear me okay? Yep, okay. So those aren't the only neurons that are affected by this disease, but it is one of the hallmarks that those neurons are affected fairly early on, enough so that many of you may have heard the statistics. Those neurons are by some estimates, by some of the research that's done, 40 to 50% of them are gone by the time you actually start experiencing your first motor symptom. And dopamine appears to be critical for proper control for many things. First of all, it's an essential neurotransmitter. It's how the brain signals to the other parts of the brain to affect certain actions or tasks or responses. But one thing it seems to be critical for is proper control of speed and amplitude of movement. And there's something about the loss of dopamine that also is responsible for generating tremor. It's not the whole story, though, and there's probably other systems involved that produce, the dysfunction of which ends up producing that tremor. Throughout this presentation, I'm trying to avoid the use of jargons, but I think sometimes it's helpful for you to know that certain things belong to a certain class of drugs. So I've put a little light bulb symbol there so that you can look at these places when you need a reminder, what is that abbreviation she's talking about. So what is on and off anyway? So the title of this talk was The Ups and Downs of Your Parkinson's Medication. And if some of you are willing to share, I'm just curious to know how many of you already feel like your medicines, it depends on the timing of your medicines. How you feel depends on when you've just taken your medicines. Any of you feel variability in how your medicines work? Okay, so it doesn't, and that's to illustrate one point, which is it doesn't happen for everybody, okay? It's probably a function of the type of Parkinson's you have. It's probably a function of where you are in the disease stage. It's probably also a function of what medications you're on. So I think that some of this may feel foreign because it's just not an issue for you, which can be a good thing. But when and if they do become a problem, this is where a lot of specialists step in and provide medication advice beyond sort of your typical standard doses. So what do we mean by on and off anyway? Well, early on with Parkinson's, especially if you get treated with a medication, you may notice that, okay, what this doctor prescribed me seems to be helping. And it's a general feeling that you have. It's such that by the time you next see your doctor 2 or 3 months later, 6 months later, you're saying, yeah, I think overall it helped. And so one doesn't really get the sense that there's an on or off. But with time, people can tend to notice that if they've been on it for a while, they'll take the pill in the morning, whatever it may be, and a few hours later they feel like, that's funny. It almost feels like I didn't take my pill. It's gradually worn off. And so this distinction between on and off really is the distinction between which of your symptoms improve with the medication and which of them return after several hours worth, or let's say you've missed a dose, or let's say you ran out of refills and you're off, and you're out of them, and you're starting to notice some return of symptoms, or some symptoms that aren't as well controlled as they formerly had been. And that could be chiefly one of three what we call cardinal symptoms: slowness, or bradykinesia is the medical term that's often used; stiffness, which is rigidity; and then tremor, for those of you who have it. Tremor is not, as we've discussed in previous presentations, it's not a requirement in terms of it's not a requirement to have a tremor if you have Parkinson's disease. And so simply on and off is the distinction between those two. And here we're talking about motor on and off. I'm not going to spend a whole lot of time on what patients might describe as non-motor offs, but that is something that some patients do experience, and it can be something that is worth discussing and addressing in the clinic. So, again, judging by the show of hands, I'm not sure that many of you will be able to apply this to yourself. But just as a rule of thumb, and just as a general principle, when we talk about on time and off time, it's sometimes useful to know how much off time someone has. So if you're generally feeling your medicines are working well for you, and you probably say, well, I'm not sure that I know what this off time business is. But if you do have it, in order to tell really how much it's impacting you, we kind of go through an exercise and say, okay, what time do you wake up? Let's say 7:30 in this example provided here. What time do you go to sleep? 11:30. All right, so we do the math. That's 12, that's 4, 16 hours of waking time, right? And so we take that waking time. Most of us don't experience a lot of, sure, sleep can be disrupted on and off, but for purposes of, sort of your moving about hours, we'll take 16 hours as your waking time. So you can think about that for yourself. Now, let's just take an example. And this is an example of a person who has pretty distinct on and offs and has a fairly rapid response. So let's say they take their medicine at 7:30 when they wake up. Well, they feel slow. They feel like it's harder to move around and, get their clothes on. So they're off. They take that medicine at 7:30, but really it's not until 8 o'clock that medication kicks in. So that's 30 minutes right there. Once it kicks in, they're doing pretty well. But by 10 o'clock, they're already starting to notice some wearing off. And that can be gradual and slow. And their doctor, let's say, has sort of written down with them that their next dose really should be 11 a.m. So they're just waiting patiently and trying to be a good patient, waiting till 11 a.m. For that next dose. And that's another hour there. So already we've got an hour and a half of off time. And then they take their 11 o'clock dose, but again, like the first dose, takes 30 minutes for that dose to kick in. Okay, so we now added another half hour. Finally, again, they've been told I should wait till 3 o'clock for my next dose, but really at around 2:30, they're starting to notice wearing off. They take their medicine at 3, but it's still taking a half hour for it to kick in. So really that's another hour of chunk time there. And then finally, they've got their 6:30 dose. Maybe they don't experience a whole lot of wearing off. Maybe by now it's actually pretty good, but they're just going to take their 6:30 p.m. dose like usual. But it also maybe noticeably better after a half hour. So we'll call that off time too. So do the math. How much off time is that?
Too much.
Everyone's got the concept? About how much off time is that, roughly? Yeah, 3+ hours, like about 3.5 hours. So really out of their 16 hours, they're spending close to 25% of that time off. And so when we talk about that, this is useful because when we talk about therapies that are designed to help smooth out these ups and downs, we're talking about this metric as being something that's meaningful to patients and something that we can measure to say, aha, okay, this medicine is expensive, but it works better, or whatever. And so try to think about that. And so when you go home, if this is a problem for you, you try it with using the example provided here and try and see what you get. Diaries can be helpful too, and I think we brought up some examples of a diary. One of the things that sort of will come out of this talk is maybe, how you can communicate with your neurologist about what your medicines are doing and how they're doing. Simply telling them, my medicines aren't working, typically isn't that helpful. What's more helpful is a schedule where you've written out 8 a.m. I take 1 tab-cinnamate. 11 p.m. or 12 p.m. I take 1 cinnamon and 1 Mirapex or something. That even just at the most basic level, that's helpful. I think a lot of you do that already. But for those of you who haven't started doing that, it's, I think, quite helpful, and it really facilitates letting your doctor know what's going on. Sorry, this keeps shutting off. All right. But in addition to that, though, the diaries, the example diaries we have here, you can put yourself into one of these categories. So far, we've talked about on and off, but there's really actually sort of a third category. And for those patients who have dyskinesia, that's sort of like a third category. And I'll explain why. It's really typically seen when you're on medication, but having too many involuntary movements. Now, knowing a lot of you, it's really common for patients to not even recognize they're having their dyskinesias. And that's okay, because then by their definition, they're probably not that bothersome. Unless, of course, there's a scenario where, okay, maybe the patient themselves don't recognize dyskinesia, but their caregivers notice they are, and they're falling out of their chair, and that's a problem. But rarely is that disconnect there. I think most of the time when patients notice them, they begin to become bothersome. When they're not that noticeable, they don't tend to be. So a diary like this, you would also, you note on the side of this, maybe in the column, over here in the white space, you could put your medications. I don't know, you could just find a spot here. This isn't working all that well, but just find a spot, put your medications. You see the 6, 7, 8, 9, and then put yourself into one of those categories. Simply put a check mark. Or you could just write it on. And although it's maybe a little overkill to do this every half hour, for some patients where we're really getting into real complicated medication regimens, maybe that's the case. But even just a general throughout the day, periodically you check in, it helps you be also more self-aware of when you think your medicines are or aren't working well. Now, that is to say, is it absolutely horrible to be off at any time of the day? No, I think we have to be realistic. I think as we talk later in this presentation about more aggressive therapies, they have their side effects too. So I think you also need to make the distinction. Is this a manageable off time, or is this, I really can't do anything during this time? And if you make that clear in your head, you can also communicate that to your neurologist and say, no, this is a real problem, versus, no, I think it's okay. I think we can stay where we are right now. So why does on even happen? And that's really just the fundamental question of, why do these medicines work? In this condition, any drug that boosts dopamine production in the brain will help a Parkinson's patients. But it depends on a few things. And, I'm sure you've noticed too, even, talking amongst yourselves or other patients or friends, that have Parkinson's, people's responses vary considerably. It probably depends partly on how many neurons are there to begin with, how much neuron loss, we talked about that at the beginning, how much neuron loss has already occurred, because these are the neurons that actually receive the drug. And so how many neurons are then available to make the dopamine if needed? And then another function of how on someone might feel is how much drug is actually used. And not even how much drug, but what's that potency of that drug? Is it a really milder sort of potency medication, like, say, rasadvaline? Or is it a really potent medication, like 200 milligrams of levodopa? And so that's going to also depend. That's also going to sort of predicate how much on you feel with the medication. So let's take, for example, carbidopa levodopa. What is it? How does it work? levodopa is actually an amino acid, and an amino acid is really just a building block that makes up a protein. It can get to the brain from the blood. Levodopa can, but dopamine cannot. Luckily for us, we know that the body can convert levodopa to dopamine. It gets converted by an enzyme called AAAD, or aromatic amino acid decarboxylase. And that lives in the gut and in the brain. If that enzyme, though, is active in the gut, you get a flood of dopamine to your gut. That's not necessarily a good thing. In fact, people can get very nauseated if they were just to take pure levodopa. So if you've ever wondered why my drug says Carbidopa, levodopa, it's because Carbidopa, you need that to block AAAD. Because unless you have it, you're just going to get a ton of dopamine to your gut. It's going to make you nauseated, and it probably won't work very well because it's all been metabolized there instead of trying to get to your brain. So, so I think that's the first thing that you should know about. And so that 25/100 or that 50/200 notation that you see on your medications, that is the first number designates how much carbidopa you get. Occasionally, some patients need additional carbidopa. It's usually for the reason I mentioned earlier, which is nausea. And maybe for whatever reason for that person, they just have a lot of that enzyme really active in their gut, and they get really nauseated because all that levodopa gets converted to dopamine there. So sometimes we supplement, and you can actually prescribe carbidopa separately. So for patients with nausea, it's really not that common, but that is one thing. So I mentioned this as a point of, I was given carbidopa, levodopa, but I'm not having a good response to it, or I can't tolerate it. Has anyone tried anti-nausea medications? No, by the way, there's certain anti-nausea medications you should not take as a Parkinson's patient. It could make your Parkinson's worse. But there are a couple that are safer. And then number two, has your doctor tried a little extra carbidopa, just in an effort to be able to tolerate this medication, which probably is one of the better medications we have. So it's nice to be able to have the opportunity to give it a nice try. So like all drugs stop working at some point. You have to repeatedly take them to keep their effect going. So when does dopamine action stop? Well, if you take a look at the neuron, which I didn't put a picture of, the neuron releases dopamine. It's trying to use that dopamine to signal to the next neuron. So there's the space in between the two called the synapse. And when it's been floating around in the synapse for a while, that dopamine usually gets taken up back into the neuron, or it gets broken down by two enzymes, MAO or COMT. And it's not really relevant, but if you want to know what the full terms are, they're at the bottom. That's monoamine oxidase and catechol-O-methyltransferase. And the reason that's relevant is I'm going to be talking about a couple other classes of drugs that act on those enzymes. So what are those enzymes? What are those drugs doing? They're trying to stop the dopamine from being broken down too quickly in that gap between the neurons, because that's where all the action's happening. So can we prolong dopamine's action? Well, yes, we can. So we try to use MAO inhibitors, and that's what Azilect or rasagiline is, or the older version of it is selegiline, which not a lot of people take anymore. And another version of this is COMT inhibitors. So it's Comtan or entacapone or Tasmar or tolcapone. And commonly it's bundled together with carbidopa, levodopa, the entacapone is. So you may have heard of a medication called Stalevo. And that's really just carbidopa, levodopa, and entacapone. So it's a combo pill of 3 drugs in it. But in general, levodopa's half-life is only 60 or 90 minutes. And you're probably thinking to yourself, well, how can that be? I take Cinemed 3 times a day, and there's a good 6 or 8 hours in between. And that's really because we are talking about giving neurons building blocks of dopamine so they can take it up and store it and release it when it thinks it's necessary. So I'll go over that again in a subsequent slide. So given all the problems that I've mentioned some people have or they wear off too early, Why isn't there an extended release carbidopa levodopa? Well, actually there is. In fact, there's two versions of it now. The old version of the carbidopa levodopa extended release is often called CR or controlled release. But there's a couple of things to know about it, and it can be used advantageously or it can be a disadvantage. And that is that it's about only 50 or 60% as potent as the immediate release. Most carbidopa levodopa that's prescribed is probably immediate release. You may not notice it, but it will probably say an IR or immediate release. So we have to adjust for that if we're trying to use it and have it be somewhat equivalent to your usual immediate release. The other thing about it is there's a term in pharmacology called bioavailability, and that's how much is, after you ingest a pill, how much of the drug actually gets taken up by your system, bioavailability. And controlled release carbidopa levodopa can be somewhat erratic. So for people who are having erratic responses, it's probably best to take them off of this and put them onto something a little bit more predictable like immediate release. That being said, I have some patients for whom immediate release is just too much all at once, and they really find that the controlled release is a little bit more gentle in terms of, the effect of the medication kind of coming on all at once. Dietary is a new carbidopa levodopa extended release, and it's new as of last year, I believe. And it's interesting for a couple reasons. The company has tried to make it kick in quickly, like an immediate release, but really have it last quite a bit longer. So trying to take the best of the immediate release and the controlled release and combine it into one pill. It's only about 30% as potent as the old standard immediate release carbidopa levodopa. And that's not necessarily a bad thing. It just means that your doctor has to calculate what is an equivalent dose for you. And it's kind of scary, and we talked to patients about this. It looks like a lot because you're almost tripling the dose. And the other thing that's funny about this medicine is instead of 25/100 or 50/200, they've decided to take 10% off of it, or about 10 or 20% off of it. So now you have doses like 45, 145, and 45, 195. So it can get a little confusing. It does appear to last a bit longer if you look at the curves of how, where they measured in the bloodstream how long it stays in the system. But at best, it's probably maybe 40% longer. And I would say really in clinical practice, results vary quite a bit. And it's still unclear yet how best to use this. Sometimes we've noticed that patients do better. Let's say they're already on a combination of immediate release and controlled release, old carbidopa levodopa. Sometimes maybe the Dietary is a more effective substitute for the controlled release, but not necessarily for the immediate release. So this is something that is still being worked out, and we're talking to your doctor if you, again, are having the problem of medications not lasting quite as long. So there's really like a ladder of Parkinson's drugs. At the top of that ladder is carbidopa levodopa. What do I mean at the top? I mean that it is still probably the most effective, most potent medication for this, because what we are doing is getting actual dopamine out of this drug. The next group is really meant to be a supplement, or what we call an adjunct medication, so you don't ever use it on its own, but this can be pretty potent as well, the entacapone or the tolcapone. I'll talk about the side effects of this drug later, but whenever we're trying to boost dopamine, we are enhancing the risk of dyskinesias. And so that's something to keep in mind. Dopamine agonists are sort of the next class down. And agonist is a term for a chemical that looks very similar to another chemical structurally. And because of that structural similarity, it binds to similar sort of as you will, stations on the neurons that it's trying to communicate with. So it achieves a similar response, but it's not entirely exactly similar. And so these medicines, pramipexole, ropinirole, rotigotine, they're all designed to mimic dopamine, but they are not actually dopamine. They do not actually ever become dopamine. I'm sorry, COMT is on there twice. MAO inhibitors are, as we mentioned, they stop the breakdown of dopamine in the synapse, that gap between the two neurons where they're trying to communicate. And those can be useful, but quite honestly, in terms of the clinical studies and also clinical experience, their effect on Parkinson's symptoms is considerably less than the other ones that are higher up on this ladder. But they're fine to use, and if they meet your needs, it's fine to take them. And then I'll mention at the bottom, there are some non-dopamine drugs that a couple people take. One's called amantadine, the other one's called trihexyphenidyl. Both of them can be helpful for tremor. Trihexyphenidyl can be helpful for dystonia. Some patients have a real abnormal posture of a foot, for example. It can be helpful for that. Not very, it's not a common occurrence. And then amantadine can also be used when people do start having dyskinesias. It's one of the only medications we have that seem to have a response in a good portion of people. All right, so why does OFF happen? Well, from the time that you've taken your medication, drug levels drop as the time passes since the prior dose. So that means there's less drug available for neurons to use. But as I mentioned earlier, there's this concept that as the disease advances, there are just fewer neurons around to take up the L-Dopa and make dopamine out of it and store it. Inside your neurons, you have little storage packets called vesicles, and that's where the dopamine lives while it's waiting to be released when needed. So what can we do about it? Well, there's several strategies when it comes to pills. We can simply increase the frequency. Just like that example I gave where that person is patiently waiting until 11 o'clock because that's what they had previously agreed upon with their doctor. But really they're starting to wear off at around 10. And that's what those diaries are useful for, because if there's a pattern and you're consistently wearing off an hour or a half hour before your next dose, that's a no-brainer. That's a light bulb to the doctor that says, oh, we need to change the timing of your medication. So that's one way to do it. Another way to do it is to increase the dose. So if you take one tablet and you just go to 1.5 tablets, chances are good that that tablet will last you longer. Question is, whether or not it will bring on side effects like dyskinesias. So in general, a lot of people, to avoid that problem, tend to take their medications more frequently, but with smaller doses. You can add a COMT drug like entacapone or tolcapone. One of the drugs I mentioned help prolong the activity of dopamine in the synapse. These can bring on dyskinesias, so you would always take this is an adjunct medication, so you would always take this with your carbidopa, levodopa. You may need to reduce your levodopa because of this activity here. You could add a dopamine agonist if you're not already taking one. That's pramipexole, ropinirole, or rotigotine. I don't have a slide on here about side effects of these medications, but you should know about them. They can be fairly considerable. The biggest one is sleepiness during the day. It's true that everyone feels tired because of the weather, maybe tired because you have Parkinson's and you're pooped because you're done with your boxing class. But if you are tending to fall asleep more than you should have, you should make a note to yourself and think, could this be my dopamine agonist? It's worth thinking about. And side effects probably increase with age. So maybe you started taking it when you were 55, but by the time you're 70, is it causing more harm than good? It's quite possible. So that's why you should always review these things. And if sleepiness was not a problem early on, but now it is more of a problem, that's again something to think about, recalibrating your medications as you get older or as you've had more years of the disease. That's very commonly needed. And then finally, you could add MAO inhibitor like rasagiline to, again, try to lengthen the amount of time that dopamine is active in the synapse. So all of these could be added to the carbidopa levodopa. Conversely, if you're not already on carbidopa levodopa, you might start with the MAO, you kind of go up the ladder. You might start with the MAOB inhibitor like the rasagiline. Then someone may add or substitute a dopamine agonist, seeing if that works any better. You wouldn't take entacapone or tolcapone until you're on levodopa. So probably the next thing after the dopamine agonist typically is the carbidopa levodopa. So that's kind of the rule of thumb. So what about dietary concerns? What else can we do about off? Well, as I mentioned, levodopa is an amino acid, and it gets all chemicals in our body get taken up because they match. They fit like a key in a keyhole somewhere, and they go, oh, I recognize this. I know what to do with this. And that's the same thing with amino acid. The problem is when we eat yogurt or milk or protein of any sort, meat, those amino acids look a lot like levodopa. So here's your stomach deciding, which do I take up? Oh, I'll take this protein from the meal. So it's okay to eat protein. I think that occasionally we do see patients who become so afraid to do that for concern of making their medication less effective. And that's a valid concern, but it's important to keep muscle mass and bone mass up and your caloric intake up. And if you're someone who's going to be prone to losing weight, probably not a good idea to be a completely protein-free diet. So it's okay to eat it. Probably just makes sense to eat your pills on an empty stomach, or at least an hour after you've had your last meal. And just avoid timing the protein together with your Parkinson's medications. And just waiting an hour or so is usually sufficient. I talked about these already, but it's a good time to talk about what are some of the side effects. So in entacapone, you can take it with every dose of levodopa. Also, again, it's packaged in that medication, Stay-Levo. It can cause diarrhea in about 10 to 15%. Urine discoloration is really common. It looks like this really yellow-orange thing, but it's not blood. It's harmless. And that's real common with its other cousin in the same class, tolcapone. Tolcapone is different, though you only take it 3 times a day. It's also different because early on they underestimated the risk of inflaming the liver and causing liver failure. So there were a couple instances very early on where it did cause severe liver damage and death in a couple of individuals. Since then, I think it's probably just been used less because people are concerned about it. But of the two, it is more potent, so it can be more effective for you. You have to have your liver function test monitored with blood tests every month for the first 6 months or so. So it also has the same urine discoloration and small risk of diarrhea as well. So then we turn to dyskinesias. Well, first of all, what are they? And I thought it would be useful at this point to try to view a video of it.
Back to the Future was a film that helped define the 1980s and made Michael J. Fox a star. More hit movies followed, as did a string of awards for his TV series like Spin City. Now, though, his future's increasingly defined by Parkinson's disease.
As soon as I wake up, I can't go back to sleep. I mean, it starts going. So I would say that's the toughest part in the morning is to kind of go, well, I'm up whether I like it or not, I'm up now. And the other thing that happens to me in the morning, first thing is I get that dystonia, which is kind of cramping, and it can be very extreme.
In a rare interview on ABC, he spoke about the new challenges from something as simple as using a toothbrush.
Sometimes I have to put the brush down on the countertop, hold it flat, and get the bristles on, because if I hold it, I'll miss it. It's a moving target. But then once I get all loaded up, then I just kind of bring it up to my mouth and then just let it go.
Remarkably, he also revealed that ice skating appears to temporarily block his symptoms, but only while he keeps moving. There's no cure for Parkinson's, but Michael J. Fox has been fighting to change that.
That's really all I wanted to show you. And there too, I think that it's been said too that how much you take is definitely part of how much dyskinesia you develop. So for someone like him, he knows he's about to be on national TV. He's probably going to take a little extra so he can appear a bit more animated. So this may be even a little bit of an overestimate, but it's not atypical. This is actually quite typical of some of the dyskinesia we see. Sometimes it's even more subtle than that, and it may be just a little shoulder here, and that's it. I mean, he's kind of got the whole body involved, but it can be very focal as well. And it can even just look like someone's just a little fidgety and restless. And, you know, plenty of patients will sort of incorporate something into like twirling something, and it's not very noticeable in those instances. So why does that happen? Well, if you give a patient without Parkinson's disease levodopa, they're not going to develop these dyskinesias. So it's really part of the Parkinson's disease. It's probably the loss of the dopamine neurons in the brain. It's probably also involving other neurotransmitters. Neurotransmitters are the other chemicals in your brain that help signal to the different parts of the brain to essentially make it work. And there's a chemical called glutamate, which might be actually overactive in individuals who are experiencing dyskinesia. And then the last issue is that scientists have been concerned for a while that by taking your 1.5 pills or whatever, 1 pill every 4 hours, you're putting in a whole load of dopamine all at once, and then you're waiting 4 hours, and then you're giving another big boost of it. And is that overstimulating those dopamine receptors, those keyholes that fit the dopamine, which is the key? And is there a way to make more dopamine but make it be more steady so that we're not trying to encourage this sort of maladaptive activity from occurring? So what can we do about them once you develop them? Well, you can alter really the dopamine medication dosing. It's not a foregone conclusion that once you develop them, you have to look like that all the time. No, you can simply lower your levodopa dose. And by dose, I mean each time you take it, how much are you taking each time? If you're already on the entacapone or the tolcapone, you might want to consider getting off of that if lowering the levodopa dose doesn't work. Sorry. You can also reduce the frequency of the levodopa dose. This is a little bit less successful, but for patients who are taking it every 2 hours and they're having dyskinesias, they're just accumulating. They're just sort of banking more and more dopamine, and by the end of the afternoon, they're really got a lot in their system. So sometimes we talk to them about, stretching them out just a tiny bit. But it can be hard because you might feel like you're sacrificing some benefit from it. We'll talk about that. You could add amantadine, and right now it's still the only medication that we know of that's somewhat effective for quelling these. It's an interesting medication. It was originally designed to fight the flu. It's not very good at fighting the flu. It sort of has been saved from the drug graveyard by the fact that it's the only medication we have to treat Parkinson's dyskinesias. And it's kind of an interesting drug in that it's not really clear how it works, and the mystery of dyskinesias is still being unraveled, but it's sort of anti-glutamate, which is what I mentioned earlier as being somehow important for developing dyskinesias. It can cause some unusual side effects. Hallucinations can occur with it, so we start real low, especially in older patients. In younger patients, we don't really have this issue. But it can cause leg swelling or lacy purple discoloration on the legs. And so that can be bothersome enough that people have to stop it. This doesn't happen too often, but rarely dyskinesias can be an off phenomenon. I've talked to you about dyskinesias coming on when your doses are too strong. Usually if people have it as an off phenomenon, it's coming on, it's there as your medicines are kicking in and there as your medicines are wearing off. So it's not usually only when you're wearing off medication. So it can be made easier to diagnose if you have both those things going on. And another telltale feature of this, again, it's pretty rare. We've only had maybe a handful of these over the years, is that in the evenings the dyskinesias are exceptionally worse, and there can be recognized by a very violent sort of bicycling kind of kicking movement of the legs at times, and that can be very difficult to treat. And the solution really, again, is to make dopaminergic dosing more around the clock, even doses, smaller, as even as possible. But not everyone will get dyskinesias. Again, big disclaimer, not all these things are going to happen to you. Not all of them are going to be problematic. And probably with dyskinesias, there's a couple of risk factors that probably stand out the most in the clinic. And one is the age of onset. So the age at which you first start developing your motor symptoms of Parkinson's disease. So I believe Michael J. Fox was about 28, 29 when he first developed motor symptoms of Parkinson's disease. So he was going to have a very high chance of developing dyskinesias. Partly some of that is due to just the length of time someone has to be exposed to levodopa, but there's probably also something about the disease. In younger onset patients, we tend to see in general more dystonia, more dyskinesias. These are these abnormal posturing or movements rather than the sort of garden variety too slow of a movement and too stiff of a movement. But a 40 to 59-year-old that is a person who started between the age of 40 and 59. That's a very broad range, I realize. But that person, depending on the studies you look at, but this is about an average, about a 50% chance of developing dyskinesia within 5 years of starting levodopa. By contrast, if you only started getting your motor symptoms of Parkinson's after the age of 70, it's a much smaller chance. And what's quoted is about a 1 in 6 chance of developing them over that 5-year time frame. Again, it's not when you first start levodopa, it's the accumulation of risk over time. Interestingly, more severe disease seems to be associated with it, but again, it's not clear that it's independent from the third thing, which is usually more severe disease means more levodopa. And as we've already talked about, more levodopa definitely means more dyskinesia. So it's also a principle we use to try to ameliorate them. We just try to lower them as much as we can. So if that toggling back and forth between too much, too little, oh, I reduced it, I stretched it out, I'm now wearing off, we're really stuck between a rock and a hard place occasionally. And again, this is not super common. It is common enough in a center like ours where we will, tend to see patients for whom, a neurologist may say, hey, can you check in on this person for me? I'm not sure what to do next. And because they failed sort of the typical oral medication route. And what we have now are really two options. We used to say, well, it's time to think about deep brain stimulation. We now have a second option, and that's intestinal gel levodopa. So I'll first talk about DBS. It's been around a bit longer, but intestinal gel levodopa has actually been around longer in Europe than it has in the US. So it's worth mentioning some things about that as well. So what is DBS? It's deep brain stimulation. It's simply high frequency but very low current electrical stimulation of the structures, your deep brain structures, not the surface ones, using electrodes that a surgeon has to implant. And it's been FDA approved actually since 1997, so we're coming up on nearly 20 years. And it came about in the 90s because surgeons, what they were actually doing, brain surgeons were actually destroying small parts of the brain similar to where these electrodes go. In fact, they would use the electrodes to find the area. They would turn on a little electricity and go, oh, that stopped the tremor. This must be the right spot. Okay, fine. Turn off the electricity. Let's send the heat in. And the heat would destroy the tissue, a small area of tissue. Those were called lesioning surgeries. When cardiac pacemakers came around, people said, hey, if we don't have to destroy the tissue, we can just have a person wear a battery that just provides the electrical stimulation. Well, that's just as good, and we don't have to destroy tissue. That's how DBS came around. And so it's effective for tremor of both Parkinson's type and essential tremor type, but it also was approved for Parkinson's disease back in 2002. And then dystonia, separate from Parkinson's, dystonia as a sort of its own disease, was also approved shortly thereafter. So about 100,000 patients, it's probably much more than that now, have been implanted with deep brain stimulations electrodes worldwide. And probably 2/3 of those or more are Parkinson's patients. So what exactly happens during DBS surgery? Well, it has its notoriety for a couple of things. One is this frame that you sometimes have to wear. Different surgeons do it differently, but this is how it's been done here since the beginning, since we started doing these in 1994. This frame is really like a map for the surgeon because we don't have the benefit of seeing exactly direct visual confirmation of where we're going to go. We need special targeting tools to map onto your MRI or CAT scan. You go to the operating room with this head frame on, and most people are awake for this procedure so that the surgeon can monitor and make sure that you're not having side effects as the surgery is occurring. But also to confirm that once they turn this test stimulation on in the operating room, that appears to be a good place. Once that's done, everything is stored up here and saved for the second surgery. At the second surgery, it's just an outpatient surgery where a battery is implanted in the chest, and they take that wire and hook it up to this battery, and now everything's plugged in and ready to go. The programming doesn't happen until about 2 or 3 or 4 weeks later when you come to the clinic and the clinician turns on the device, and that's how the electricity is applied. It's set at a certain setting, and then it supplies electricity 24/7. But there's probably a window of opportunity for DBS, and it's worth thinking about. because in the old days, I think clinicians used to be concerned about the timing being too early for DBS. Oh, Mr. Smith, you haven't tried this or that. Let's try this or that, and then we'll see. But I think more frequently the problem is we're seeing patients who probably either one or two things. They don't have the disease characteristics that would lend itself to benefit from deep brain stimulation, or it's so far along that it makes it difficult to go through this process. So usually I would say the average is between 5 or 10 years of Parkinson's disease symptoms. Now again, some of you may have 5 or 10 years of Parkinson's disease symptoms, but you're not having trouble with your medications, and that's fine. Doesn't mean you should be having DBS just because this timing window is there. So that's not at all what it's implied. But on average, that's what's been happening at our center here, at least the type of patient we're seeing. It's someone who's probably on levodopa frequently. What is frequently? It's somewhere north of 4 or 5 times a day, and it can even be 10 or 12 times a day in some severe cases. They're still having a good response. This is critical. If you don't have a good response to medication, you are not going to have a good response to deep brain stimulation. So you're probably wondering, well, why would I do surgery then if I need to have a good response to medication? Wouldn't that mean I'm already doing well? It's the frequency of the wearing off and the development of the dyskinesias that bring people to deep brain stimulation, that rock in a hard place. If you're not having too much speech or walking difficulty, this is also a beneficial thing in general, of course. We don't want people to have that, but it can be something that deteriorates slightly after DBS. And so if you already have borderline bothersome speech and gait problems, you just have to be prepared that could, you have to just take it into account when you're thinking about your other symptoms that you want relieved. Is it worth it to try to do that when you know that this is a risk of deterioration in that way? Good health, generally speaking, and good support to get through the process, which requires quite a few visits. I would say 4 or 5 visits over a 6-month period of time, including the 2 surgeries. So what about this other option? Intestinal gel levodopa. It also goes by Duopa. It was actually approved in the U.S. in 2004. It was approved here last year. It is basically continuous dopaminergic therapy. What it is basically is levodopa, the drug, is suspended in a gel solution such that it comes in a pouch. And I should have brought pictures, I'm sorry. But it's suspended and it comes in a pouch. It's refrigerated, okay, just to preserve it. And the pouch contains all the drug that you need for the day. And it just gets slowly infused using a pump because you need something to push it in. Where is it going? It's going into your small intestine. And I'll show you a picture of that in a sec. What is the benefit of this? Well, a couple of things. On average, patients actually did end up using slightly less levodopa because they were able to provide it more consistently. They didn't have to give those big boluses, once every 4 hours. That off time, do you remember at the beginning we talked about how to calculate your off time? Well, between the 2 groups, believe it or not, there was a group that got a pump, but the gel didn't have levodopa in it. That group, the group that got the levodopa, noticed that they had 2 more good hours of on time throughout the day. It was actually, it was interesting. The placebo group also had an improvement. So we're talking about 2 more hours beyond the placebo benefit. And then same thing, but in the reverse direction, the on time that I talked about with dyskinesias, which is bothersome for some people. Again, the placebo group did have a little improvement. They got 2 hours more good on time without dyskinesias, but the group that got the gel levodopa had 2 more hours. So they had a total of 4 more hours of good on time without dyskinesia. So that can be substantial in a person who is already, I believe at baseline entry, all these subjects who enrolled had between 6 or 8 hours of that off time. So that example I gave you was pretty mild. That was only about 3.5, 4 hours. These are people with 6 to 8 hours of off time. So what does that look like? Well, in the bloodstream, at the 0 time, you start the pump, it starts infusing, and you basically, each of the little dots just represents someone getting their blood drawn. I mean, God bless them, they went through this study. Someone getting their blood drawn every half hour, so you can see that dopamine level remains so steady. And at that 16-hour mark, they shut off the pump and it starts to decline. And that's really by convention. People just are going to sleep at the 16-hour mark. They unhook themselves. They take the pump off so they can sleep and roll over in bed. And then they might take, extended release Sinemet at night if they're one of these people who feel like they have trouble turning over at night, then they could take that at that time. So the nuts and bolts of this is sort of a cartoon diagram of this. So a day procedure, meaning an outpatient procedure, is done to insert a PEG-J tube. That means percutaneous endoscopic gastrojejunostomy tube. Okay, in English that means a tube placed in your skin to the stomach and small intestine with the help of a camera that you swallow. That's literally what it means, okay? And so you see that here, the little light bulb, like, it's not quite that big. Everything here is not to scale, I would say. But the little light bulb is actually a flexible bulb that makes sure that that tube is not sliding back out. So it keeps it locked in place. The tube then winds around through your intestine, the latter part of the stomach and the small intestine. And there's a little opening here designated right above C, and that's what you see, coming out of the skin. And that's where the tube from this pump, this is the pump, believe it or not, in A and B. A is where you put the gel pouch. B is the actual mechanics of the pump. They are working on modernizing this. We gave them this feedback. Many people gave them this feedback. That is from the 1980s. They're working on modernizing it. But that is where the pump hooks up into the tube. And you wear it in a fanny pack, you wear it over your shoulder, you wear it tucked in. People have created apparently garments that are very ergonomic. So I expect that we'll see even better improvements in the design of this. But that's essentially what it is. So more nuts and bolts. So as I mentioned, the pouches are refrigerated. So each morning you take one out of the fridge, let it kind of come to room temp, hook it up to your pump cassette, and then put the tube in your stomach, and you let it go. And a lot of the nuts and bolts of how much to give and what's the rate and how much of an extra dose you can give yourself. That's all done with the help of a nurse in the clinic and a nurse in the home, actually, to set that. And so once you reach a satisfactory rate, you just put it on and go. And you don't do anything about it until the end of the day when you're ready for bed. Take the pump out, take the cassette out, clean it with some fresh saline water, and that's it. And it replaces your daytime pills. You don't take oral pills in addition to this. You just take this. That's it. So it does require a little bit of the manual labor of putting it on and hooking it on and taking it off at night and cleaning it. But it's so one has to take that into account when thinking about these two things. So, briefly I listed how would you even think about these two things. Well, I think for DBS, I think you have to be able to be okay with the idea of brain surgery. And I know for some patients that is just not a treatment goal for them. So we say, fine, you don't want brain surgery, we won't go there. And so we're going to try to stay away from them as much as possible. For DBS, I think it's more important that you not have significant cognitive impairment. And so I think it's also more important that you do not have significant concerns about your speech or if your walking is right on the border, and we talked about could it deteriorate a little bit. Those are important, probably more from the DBS perspective, to be as free of those as possible. Dyskinesias is interesting because we do know DBS does a very good job of relieving dyskinesias. With Duopa, it's unclear. It looks like it does because of the data that's been coming out, but we don't know we don't know how a different group of patients with more severe dyskinesias might do with this therapy. So that's why that's in a question mark. I suspect right now actually studies are ongoing to clarify that issue. But it can be helpful for dyskinesias. It's just a question of what's the cut mark. Can it be also helpful for severe dyskinesias? Duopa, I think the things that you have to think about is DBS, even though there's a lot of surgery involved and sort of in and out of programming visits for a little while. Once it's set, you kind of forget about it. You don't really fiddle with your DBS too much. With the Duopa, it's helpful to have, if you can't physically manipulate it, it's helpful to have someone to help you hook it up and take it off at night. And then you'd be able to use a little syringe to clean them out with a little, 1 or 2 tablespoons of water at night. It's kind of formatted funny, sorry, but cognitive impairment and age and speech are probably less of a concern. So those are the things that we start thinking about when we talk about these two things. So I'm almost done. Parting words, other ways to make your medicines work for you, not the other way around. Medication schedules written out are very helpful. Try an on-off diary. If you are having some erratic performance, you might discover the problem yourself and figure it out before your doctor does. And then I think, ask your doctor for refills each time you see them in clinic. I think it's worrisome sometimes when people feel like, oh my gosh, I'm out of refills, I'm in a panic. I think if you make it a routine and get them refilled at each time or get them reconciled each time you see your doctor, it's a good habit to go over medicines every 6 months anyway. Things change, side effects may develop, you may not realize it, or new stuff may come out. So it's a good opportunity to review those things. And then in between visits, your pharmacist is a really valuable resource. It's very efficient. They send a little message to the doctors electronically. They can also tell you, oh, no, you're not out of refills. You have this other prescription waiting here to be used. I was like, oh, great. So it can save you a lot of time, too. And that's it. Thank you for coming. Thank you for our awesome staff, including Althea and Lauren. And check out our website and the National Parkinson Foundation website, too.